Welcome to MRCPology channel for quick review, understanding of the topics, and a stepwise approach to the PACES exam. Myopathies are primary disorders of skeletal muscle. The main clinical consequence is weakness caused by failure of the muscle fibers to generate normal force. The typical pattern is symmetrical proximal weakness. The patient struggles with activities that require the large muscles of the shoulder and pelvic girdles. Sensation is usually normal because the sensory nerves are not primarily affected. Tendon reflexes are often preserved during the early stages because the sensory nerve, motor nerve, neuromuscular junction, and reflex arc remain intact. Reflexes may become difficult to elicit later when the muscle is too weak or too severely wasted to produce a visible contraction. It is important to clarify that inherited myopathies are a broad group. Muscular dystrophies are inherited myopathies characterized by progressive muscle fiber degeneration, but not every inherited myopathy is a muscular dystrophy. Other inherited disorders include congenital, metabolic, mitochondrial, and channel-related myopathies. Most myopathies predominantly affect proximal muscles, but there are important exceptions. Inclusion body myositis characteristically affects the quadriceps and the deep finger flexors. Myotonic dystrophy may produce distal limb weakness, facial weakness, neck flexor weakness, ptosis, and myotonia. Recognizing these exceptions prevents us from incorrectly excluding a muscle disorder simply because the weakness is distal. The key localization is dysfunction within the muscle fiber. This must be separated from disease affecting the central nervous system, peripheral nerve, anterior horn cell, or neuromuscular junction. A central nervous system lesion usually produces upper motor neuron signs, such as spasticity, brisk reflexes, clonus, or an extensor plantar response. A peripheral neuropathy usually causes distal weakness with sensory loss and reduced reflexes. A neuromuscular junction disorder produces fatigable weakness, often involving the eyes, face, bulbar muscles, or respiratory muscles without sensory loss. In a myopathy, the classic combination is proximal weakness, normal sensation, and relatively preserved reflexes. The main mechanisms of myopathy can be divided into inflammatory, metabolic, mitochondrial, endocrine or toxic, and inherited structural muscle disease. This classification is clinically useful because each mechanism produces different clues, investigations, and treatment priorities. Inflammatory myopathies are caused by immune-mediated injury to muscle tissue. The immune process damages the muscle fibers, their supporting microvasculature, or both. This leads to muscle fiber dysfunction, and in many cases, active fiber necrosis. The result is usually subacute symmetrical proximal weakness. Myalgia may occur, but its absence does not exclude inflammatory myopathy. Creatine kinase, or CK, is often raised because injured muscle fibers leak intracellular enzymes into the circulation. The important inflammatory myopathies include polymyositis, dermatomyositis, immune-mediated necrotizing myopathy, and inclusion body myositis. Dermatomyositis combines muscle inflammation with characteristic skin manifestations. Look for a heliotrope discoloration around the eyes, Gottron papules over the knuckles, a photosensitive rash over the upper chest or back, and periungual changes. In an adult with dermatomyositis, remember the possible association with malignancy and assess the patient in the appropriate clinical context. Immune-mediated necrotizing myopathy often causes marked proximal weakness with a very high CK. It may be associated with autoantibodies, malignancy, or exposure to statins. Importantly, statin-associated autoimmune necrotizing myopathy may continue despite withdrawal of the statin because an immune process has become established. Inclusion body myositis behaves differently. It usually progresses slowly and commonly affects older adults. Weakness may be asymmetrical. The characteristic pattern is weakness of the quadriceps and deep finger flexors. The patient may report falls because the knees give way, difficulty rising from a chair, or difficulty gripping objects. Dysphagia is also common. Inclusion body myositis often responds poorly to conventional immunosuppression compared with other inflammatory myopathies. Metabolic myopathies result from failure of the biochemical pathways that generate energy for muscle contraction. Muscle needs a continuous supply of ATP. When energy production cannot meet demand, the patient develops exercise intolerance, painful cramps, fatigue, or rhabdomyolysis. The timing of symptoms in relation to exercise provides an important diagnostic clue. Glycogen storage disorders tend to cause symptoms during brief, intense activity or early in exercise because glycogen is needed rapidly at the beginning of muscular activity. Patients may experience cramps, contractures, or myoglobinuria after sprinting, climbing stairs quickly, or lifting heavy objects. Disorders of fatty acid oxidation tend to cause symptoms during prolonged exercise, fasting, fever, or other catabolic stress. During prolonged activity, the body increasingly depends on fatty acids for energy. If this pathway is defective, the muscle becomes energy depleted and may undergo rhabdomyolysis. Myoglobinuria produces dark or cola-colored urine following muscle injury. It is clinically important because myoglobin can damage the kidneys. In a patient with suspected rhabdomyolysis, assess CK, renal function, electrolytes, urine findings, fluid status, and the risk of complications such as hyperkalemia. Mitochondrial myopathies are disorders of oxidative phosphorylation. Mitochondria generate ATP through aerobic metabolism. Tissues with high energy requirements are therefore affected most prominently. These include skeletal muscle, extraocular muscles, the brain, the heart, the retina, and the auditory system. Patients may present with exercise intolerance, early fatigue, ptosis, external ophthalmoplegia, hearing impairment, seizures, cardiomyopathy, diabetes, or other multisystem features. Lactic acidosis may occur because pyruvate is diverted towards lactate when oxidative metabolism is impaired. The combination of ptosis, or ophthalmoplegia, with systemic neurological, cardiac, endocrine, or auditory features should raise suspicion of mitochondrial disease. The absence of a markedly raised CK does not exclude it because the primary abnormality is failure of ATP production rather than widespread rupture of muscle fibers. Endocrine and toxic myopathies disturb muscle metabolism, protein turnover, or muscle fiber structure. The resulting weakness is often proximal and may develop gradually. Hypothyroidism may cause weakness, cramps, stiffness, delayed reflex relaxation, and sometimes a raised CK. Hyperthyroidism more commonly causes muscle wasting and proximal weakness, often with a normal CK. The patient may also have tremor, tachycardia, weight loss, heat intolerance, or other features of thyrotoxicosis. Cushing syndrome and prolonged corticosteroid exposure cause a characteristic proximal myopathy. Steroids increase protein catabolism and cause selective atrophy of type 2 muscle fibers. Because there may be little active muscle fiber necrosis, the CK is usually normal. The weakness commonly affects the pelvic girdle, making it difficult for the patient to rise from a chair or climb stairs. Drug and toxin exposure must always be reviewed carefully. Statins can produce a spectrum ranging from mild myalgia to toxic myopathy, rhabdomyolysis, or immune-mediated necrotizing myopathy. Alcohol can cause an acute painful myopathy with rhabdomyolysis or a chronic proximal myopathy related to toxicity and poor nutrition. Colchicine may produce a myopathy, particularly in patients with renal impairment or important drug interactions. A complete medication history is therefore part of localization and diagnosis, not an administrative detail. Inherited muscular dystrophies result from genetic abnormalities affecting structural or functional proteins within muscle. When proteins responsible for membrane stability are defective, repeated contraction damages the muscle fiber membrane. This causes recurrent fiber injury, degeneration, and attempted regeneration. Over time, healthy muscle is replaced by fat and fibrous tissue. The weakness therefore becomes progressive. Different muscular dystrophies produce different patterns of weakness, age at presentation, inheritance, and systemic involvement. Cardiac and respiratory muscles may be affected. Some patients develop contractures, spinal deformity, or calf enlargement caused by fatty and fibrous replacement rather than true muscle hypertrophy. PACEs do not stop after identifying proximal weakness. Look for the pattern, severity, distribution, associated contractures, scapular winging, calf enlargement, facial weak cardiac clues, respiratory involvement, and family history. These features help distinguish one inherited disorder from another. The classic clinical presentation of myopathy is symmetrical proximal weakness. Pelvic girdle weakness causes difficulty climbing stairs, standing from a low chair, getting up from the floor, or walking uphill. Shoulder girdle weakness causes difficulty lifting objects overhead, reaching a high shelf, washing the hair, or putting on clothing. The large anti-gravity muscles reveal impaired force generation early because everyday activities place a significant demand on them. A patient may have enough strength for simple movements on the bed, but still be unable to rise from a chair without using the arms. Normal sensation is a major localization clue. Ask about numbness, tingling, burning pain, and sensory ataxia. Then examine light touch, pinprick, vibration, and joint position sense as clinically appropriate. Objective sensory loss should make you reconsider a pure myopathy and look for a neuropathy, spinal cord disorder, or combined process. Reflexes are usually preserved until weakness becomes advanced. This is because the reflex arc remains structurally intact. However, a severely weak muscle may produce only a small movement despite an intact reflex response. Reflexes must therefore be interpreted alongside muscle bulk, power, tone, and sensation. Myalgia is variable. Some inflammatory, toxic, metabolic, and infectious muscle disorders are painful. Other myopathies cause profound weakness without pain. The presence or absence of pain alone cannot confirm or exclude muscle disease. Certain clinical clues help narrow the differential diagnosis. A characteristic rash suggests dermatomyositis. Dysphagia may indicate bulbar or pharyngeal muscle involvement and can occur in severe inflammatory myopathy, inclusion body myositis, muscular dystrophy, mitochondrial disease, or other neuromuscular disorders. Respiratory weakness is a serious feature. Ask about breathlessness, orthopnea, morning headache, weak cough, recurrent chest infections, and sleep-related symptoms. Weakness of the deep finger flexors combined with quadriceps weakness strongly suggests inclusion body myositis, particularly in an older patient with slowly progressive or asymmetrical weakness. Test finger flexion carefully rather than relying only on grip strength. Exercise-induced cramps, muscle pain, rhabdomyolysis, or myoglobinuria suggest a metabolic myopathy. Clarify whether symptoms occur immediately after intense activity, after prolonged activity, during fasting, or during illness. The timing reflects the energy pathway being used and is therefore diagnostically valuable. Ptosis and ophthalmoplegia raise the possibility of mitochondrial or oculopharyngeal muscle disease. However, they can also occur in neuromuscular junction disorders. Look for fatigability and fluctuation, which support a neuromuscular junction disorder, and for multi-system features, which may support mitochondrial disease. To understand these patterns quickly, revise the proximal myopathy examination, neuromuscular junction disorders, peripheral neuropathy, and mitochondrial syndromes on this YouTube channel. These are the principal localizations that must be separated during PACEs. Diagnosis begins with localization. A lower motor neuron type pattern of weakness, particularly proximal weakness, with normal sensation and no upper motor neuron signs suggests muscle disease. A raised CK strengthens the suspicion but is not essential. The core blood tests include CK, urea and electrolytes, liver biochemistry, thyroid function, inflammatory markers, and relevant autoantibodies when inflammatory myopathy is suspected. A medication, supplement, alcohol, and toxin review is essential. AST and ALT are commonly described as liver enzymes, but they are also present in skeletal muscle. A patient with muscle injury may therefore have raised transaminases without primary liver disease. Interpret these results alongside CK, bilirubin, alkaline phosphatase, gamma-glutamyl transferase, symptoms, and the wider clinical context. Autoantibody testing may help identify a specific inflammatory myopathy phenotype and associated risks, such as interstitial lung disease, malignancy, or immune-mediated necrotizing disease. The result must always be interpreted with the clinical pattern. Electromyography in myopathy typically demonstrates short-duration, low-amplitude motor unit potentials with early recruitment. The muscle recruits many small motor units because each diseased motor unit generates less force. EMG can support localization, but it does not always establish the precise cause. Muscle MRI can identify the distribution of affected muscles and help distinguish active inflammation from chronic damage. Edema may suggest active inflammatory change. Fatty replacement and atrophy suggest long-standing or irreversible disease. MRI can also help select an appropriate muscle for biopsy. Muscle biopsy may be required when the diagnosis remains uncertain or when distinguishing inflammatory subtypes will change management. Genetic testing is increasingly important when an inherited myopathy is suspected. The investigation should be guided by the phenotype rather than ordering broad tests without clinical direction. CK requires careful interpretation. CK rises when muscle fibers undergo active necrosis or develop membrane leakage. It may be markedly elevated in inflammatory myopathy, muscular dystrophy, toxic muscle injury, immune-mediated necrotizing myopathy, and rhabdomyolysis. However, a normal CK does not exclude myopathy. Weakness may result from muscle fiber dysfunction, impaired energy production, or atrophy without active fiber destruction. Steroid myopathy produces selective type 2 fiber atrophy through increased protein catabolism. There is little muscle fiber necrosis, so CK is usually normal. Endocrine myopathy often causes altered muscle metabolism and atrophy rather than membrane rupture. CK may therefore remain normal, especially in hyperthyroidism and Cushing syndrome. Hypothyroidism is an important exception because it can produce a significant CK elevation. Mitochondrial myopathy is primarily a failure of ATP production. The muscle fibers function poorly, but may not undergo extensive necrosis. CK may consequently be normal or only mildly raised. CK may also be normal in chronic burnt-out muscle disease. By this stage, much of the original muscle tissue may have been replaced by fat and fibrosis. Fewer viable fibers remain available to undergo active necrosis and release CK. Therefore, CK reflects current muscle fiber injury rather than simply the total degree of weakness. Treatment must target the underlying mechanism. Inflammatory myopathies are treated with appropriate immunosuppression to reduce immune-mediated muscle injury. The exact regimen depends on the subtype, severity, associated organ involvement, and response to therapy. Swallowing and respiratory function must be assessed because these complications may require urgent supportive management. In toxic myopathy, remove or replace the offending agent where clinically appropriate. In endocrine myopathy, correct the hormonal disturbance. Improvement may be gradual because muscle strength takes time to recover even after the biochemical abnormality has been corrected. Metabolic myopathies require individualized management. This may include avoiding fasting or specific exercise triggers, modifying diet, developing a safe exercise plan, and preparing for illness or catabolic stress. Patients at risk of rhabdomyolysis need clear advice about hydration, warning symptoms, and when urgent assessment is required. Treatment of muscular dystrophies and mitochondrial myopathies is often supportive and multidisciplinary. Management may include physiotherapy, rehabilitation, mobility support, prevention of contractures, genetic counseling, and regular cardiac and respiratory surveillance. Some inherited disorders now have disease-specific treatments, so precise genetic diagnosis is increasingly important. In PACES, a polished summary would be, this patient has a predominantly symmetrical proximal myopathy with preserved sensation and relatively preserved reflexes. I would assess the distribution and severity of weakness, look for skin, bulbar, respiratory, cardiac, endocrine, toxic, and inherited clues, and investigate with CK and targeted biochemical, immune, electrophysiological, imaging, biopsy, or genetic tests according to the clinical phenotype. The memory hook is muscle means movement fails, but sensation remains. Proximal weakness suggests the usual pattern. A rash suggests dermatomyositis. Finger flexor and quadriceps weakness suggests inclusion body myositis. Exercise-triggered symptoms suggest metabolic disease. Ptosis with multisystem features suggests mitochondrial disease. A normal CK does not exclude myopathy because dysfunction and atrophy can cause weakness without active muscle fiber destruction. Do subscribe to the channel for further videos.